Dear students, Assalamu alaikum. I'm Professor Najam Shabir and I'm heading the Department of Surgery of Fidaiya Rutbah Medical College. We have changed the pattern of our lectures and we are going on the modular system. So therefore, we are trying to teach you from the beginning, that is in the first year, the basics problem which will occur in chest, for example. At the moment we are doing the chest module, so we are going to talk about the problems in the chest which are pertaining to the surgery. And in this, basically what we are dealing is with the trauma. Trauma is very important, and this occurs in our day-to-day life, in civil life, in domestic life, as an industrial trauma and as a war trauma. So we will tell you that what we expect from a student and a doctor to do at the time of trauma, at the scene and in the casualty and in the ward. So we will take you step by step. So welcome you again, and inshallah, because this is my first lecture, so I would like to tell you that here we work in a different pattern, and my style is, it's a teamwork basically, and we all are the player of the same team, but due to the seniority, some are the manager, having the position of manager, some are the captain, and some are the coach, and some are the players, as you people are. So give your 100% input, inshallah, and at the end of the day, we will be successful. This is a long course, not starting only pertaining to first year, but it will go to final year and beyond that as well in your post-graduation. These lectures, you might find it a little bit difficult, but once you go through again and again, then you will know the importance of these, because this will help you not only in your basics year, but also in your final year and even in your postgraduate studies. So bear with us and try to understand. If any problem, we are here and we will take you through. Thank you. In the trauma, nowadays, you are lucky you are in this era, because now the trauma is very organized. But there used to be days, even not very far away, 1976, when there was a surgeon, orthopedic surgeon, Mr. James, and he was in a small plane, and when it crashed down, and he had his family with him. And at that time, he didn't know whom he has to attend first, because he has got his children and his wife. The wife died instantly, and then there were children, and he didn't have any means to contact the hospital and how to call the ambulance. Even in that country, United States, where they are very organized, even at that time. But after that, he realizes and he said that now I have to do something good for the system, because system is not working for the common people. And from there, this idea of ATLS has emerged. And after that, this ATLS, they you have to appear in ATLS exam after every 4 years. After 4 years, you have to take the exam again, because you have to update yourself. Because by research and by practice, they keep it improving all the time. So ATLS means acute trauma life support system. This is very important. Now this is trauma. We have got this ATLS system, and we have got a BLS system. BLS is a basic life support, in which you don't use any gadgets. You do whatever you have got provided with your hands and maneuvers. You do it, and in ATLS you can use the gadgets and investigations, everything. Okay. Then we have got trauma. We've got, it is divided into two: primary survey in ATLS, and we have got a secondary survey. In primary survey, we have got A, B, C, D, E. A is for the airway. When the patient comes to you, you do the triage. Triage means you sort it out. Which patient you have to see first, which patient you see the last. If there are many patients and they are crying, and one patient who is not crying, you will go to that patient, because if the patient is not crying, that means that there is something problem with his airway. So airway is the number one thing in all MCQs. First, maintain airway. Patient is talking to you, that means his airway is intact. He's not talking to you, unconscious, airway is a problem, you have to rule it out. Okay, so with airway there is a cervical spine, and cervical spine, if you have to take care of it, if there is a small fracture and you don't handle it properly, it might cause the complete transection of the spinal cord. So you have to put the collar and then you move the patient. After that, there is a breathing. You have to see whether the chest wall is moving or not, and ventilation is taking place or not. Then you have to go for circulation. You have to put two large bore cannula, 16, because at times you have to give the blood to them. So you have to have a large bore cannulas. Okay, and then in this situation, then you can control the circulation. So always when the patient comes, or trauma patient comes to you, you always put 2 liters of ringer lactate or normal saline on the both sides, and you give it rapidly within over a period of 1 hour or 2 hours. Then you also assess their neurological status by the Glasgow Coma scale, in which there are 3 parameters. Number 1 is I, which has got 4 numbers. Then you have got a verbal command, which has got 5 numbers, and then you have got the muscular activity, movements of the hand and feet, which has got the 6 number. So total 15 number. Minimum is 3. Even the dead patient has got 3 numbers, and maximum is 15. If the Glasgow Coma scale deteriorates from 15 to 14, 13, you take it seriously. If it is more than 13, then you send the patient directly not to a local hospital but to a tertiary care hospital where there is a neurosurgery services are available. Okay. If the patient has got 7 or 8 Glasgow Coma scale, then you intubate the patient. Then you also do this ECG, then you do the pulse oximetry, then you have got the ABG, arterial blood gases, to see whether the carbon dioxide retaining or not, what is the saturation of the oxygen, and pulse oximeter also tell you about the saturation of oxygen. You just put it at your end of the finger. Okay. Then you have got the catheters. You catheterize the patient because you don't want them to retain the urine. But if there is a blood at the tip of the penis and meatus, then you don't catheterize, because that means there is a urethral damage and you might cause the further damage. So restrain. And then you can do the X-ray chest and or the pelvis or long bones, whatever you are suspecting injuries. After that, you go for the second survey for the patient from head to toe, and then they have got the ample allergies, medications, past medical history, last meal. Important, if it is less than 6 hours that the patient is taking the meal, then you have to secure, otherwise the patient might regurgitate and causes aspiration and causes the death of the patient. And then you have to know what are the events leading to injury, whether the patient was driving the car with the seat belt or on the passenger seats, or he was thrown out. That will show you the severity of the trauma. And then we have got trauma. We always classify things into different classes. It is into blunt trauma, that is if somebody hits with the stick, or there is a penetrating trauma by the gun or high velocity bullets, or by the knife. And there is a blast like bomb blast, and there is a crush if somebody the high speed vehicles passes over the limbs. It will cause the release of the myoglobin, which might go and block the kidneys and cause the acute tubular necrosis. And there is a thermal, that is on Siachen. If it's very cold, it will cause the coagulation and cause the gangrene, or if it is due to the burn due to the electricity or burn by the hot water. Now I will take you through a system which I usually take my patients, and as if you are there in a casualty or in a hospital and the patient comes to you. And first you have to read the first slide and see what the scenario is, and then I will explain to you what you have to expect from this patient and what we expect from the doctor and what measures you should take for the management. As you know, a plain rib fracture is the most common chest injury, right? So whenever there is a trauma, usually there is a fracture of the rib. Maybe one, maybe two, or maybe multiple. And bothersome but trivial in most people because of the pain. And it hurts as you take the breath in and as you breath out because of the pleuritic pain. And it is a very severe pain, mind you. It is not dangerous for the young man because they can cope, but it is very hazardous in elderly, old people, because of the pain they hyperventilate, and when they hyperventilate, their alveoli they didn't open, there is atelectasis, and there is a pooling of the fluid which leads to the pneumonia. And the treatment is you have to locally relieve the pain. You have got different methods, either nerve block or epidural catheter. We can't use the opiate because it will depress the breathing. So you should know it. Now, in this patient, after the trauma, what happened? That he develops the plain pneumothorax. And what is that? That the pneumothorax means air in the pleural space, and because of the pressure, it collapses the lung because it is over the lung. There is a collection of the air, and it will act as a drum. If you percuss over it, it will act as a drum, hyperresonant. Okay. There's another variety of pneumothorax which is known as tension pneumothorax, and this is a bit of emergency. Why? Because it will act as a one-way valve, and with every breath, the air will push more and more into the pleural cavity, and there will be more and more collapse of the lung. So in this patient, we have got little more time because the patient's vital are stable. So we will go for the chest tube with the underwater seal and suction. And where we put the chest tube, we put on the fifth intercostal space in the mid-axillary line, and the patient will be relieved because the air will be come out. Okay, I will tell you in a minute about the patient of the pneumothorax, tension pneumothorax, who is not vitally stable, and then we have to do some emergency measures, which I will let you know in a minute. Now, after the trauma, you have got this patient in front of you, and as you can see on the right side, there is a white opaque shadow on the right side of the lung. Okay, and this is the pooling of the blood, which we call the hemothorax. Okay, and next slide we will see that what to do with these patients. Okay, as I told you that there is a collection of the blood in this patient on the right side. Patient was stable. So we do the chest X-ray, which confirms that there is a pooling of the blood in the base. And in this patient, the important thing is that there will be dull on percussion, because if there is a collection of the blood, it will be dull on percussion. If it is the air, it will be hyperresonant. So there is a difference between the pneumothorax and hemothorax. In hemothorax, there will be dull on percussion, and pneumothorax, it will be hyperresonant. So this is pneumothorax, right? So what we will do, we will pass the chest tube on the right side at the base of the pleural cavity, because the blood usually pulls with the gravity at the base, and if there is air, it usually tries to go up. So if we pass the chest tube, we pass it up, try to put it up in the case of pneumothorax. In case of hemothorax, with the blood, we try to put it down. So this is a very important point. And if the blood remains there and it becomes contaminated, infected, it will convert into empyema, that is the pus. Okay. So usually the bleeding stops in the lung because lung is a low pressure system. Then what we do, we pass the chest tube so that we will take this blood out, and the amount of the blood will determine the further management. How much speed it comes, how much amount it is there. So this will all, and we will further discuss inshallah in the next slide. Now, as you saw in the previous slide, there was only a small amount of blood which was taken out with the chest tube. So we were not worried. But in this case, there is a large hemothorax, and hemorrhage from it, most probably it is hemorrhage from systemic major vessels, probably an intercostal artery. So surgical intervention is required because we have got few criteria. If you put the chest tube and there is a 1500 ml or more blood gushes out at that time, then we have to go for thoracotomy, or we have to go for thoracoscopy, and we have to stop the bleeding. Or if there is a blood more than 200 ml per hour for 2 to 3 hours, that also means that there is a major vessel leakage. Okay, now we have got another scenario. We have done with the pneumothorax, we have done with the tension pneumothorax, we did the hemothorax, okay, and in these all these the patients were stable. Then there is a case in which the patient was unstable, and in because of the large hemothorax, okay, and in that the when we pass the chest tube, the blood was 15 ml or more, or 200 ml per hour for 3 to 4 hours. In that cases, we have to do the thoracotomy. But in this case, there are both the things, hemo and pneumothorax, right? And we have to pass the chest tube at the base. And if multiple air fluid levels are present, then we have to think about the diaphragmatic injury, because diaphragm makes the abdominal cavity separate from the chest cavity. But if there are diaphragmatic injury, then the bowel loops will come up on the right side, and the left side there may be the stomach will come up, and it will show as the multiple fluid levels, and we have to suspect this, and this is then surgical emergency. So you have to be cautious, and you have to know that you have to see for these findings if there are the multiple fluid levels. But if there is a one fluid level, then you can see as in this slide that above there is air, then there is blood, and that shows that there is a fluid level at that level as well. So if there is a fluid level, single fluid level, and that means that air is above and blood is below. Okay, but if there are multiple, then we have to go and find out that what happens if, and where is the diaphragmatic injury is, and we have to mend it with the surgery. In this case, there is a explosion, and there is a chest injury, and there is a flap. The paramedics at the side said that there is a flap-like wound in the chest, and in this case, what happened that the air is going inside and only one way, right? And what you have to do at that time is to stop the air to go inside. And what you do, any clean cloth which is available, if it is gauze which is soaked in amazine, it is very good. Otherwise, any clean cloth, you just take it and just put it simply over it, and you just put the tape on the three side, okay, not on the four side, three side, so that the air will go out but not in, okay. And when the patient reach to the hospital, you will put the chest tube when needed, okay. And this is very important, in these kind of cases, you have to know that this this open pneumothorax can convert into a tension pneumothorax. So this is the importance. We discussed it before. What is the simple pneumothorax? What is the tension pneumothorax? Tension pneumothorax is always an emergency, and you have to keep it that in your mind. And in this case, you might find the subcutaneous air inside, and when you put your hand over it, you'll feel the crepitus like bubbles. If you put it as if there are small bubbles beneath the skin. So that is known as the crepitus, okay, and this is that known as the surgical emphysema, okay. Okay, now in this patient, this is an emergency, and there are multiple rib fractures, not from one side, but two or more sides. And usually, when you inhale, so the chest cage moves outside, and when you exhale, the chest cage move inside. Why? Because it would press the lungs, and the air will move out. Okay, and when you inhale, it gives more room for the air to come in, because gases always passes from higher pressure to lower pressure. Okay, so this is understand. But in this case, what happened? There is paradoxic. It will be revert. Okay, and when you inhale, it will go inside, and you exhale, it will go outside. So this is the reverse of the normal. And so we call it flail chest. Okay, and this flail chest, you have to look for the basically that the patient is usually not stable at the time, and you have to look for the dislocation injuries cause this blunt chest trauma, and there may be injuries to the lung, and because it is severe, it might causes injury to the heart, because heart is also there, and it will cause the myocardial contusion, and we have to monitor the blood gases in these cases whether the patient is deteriorating or not, and there might be a traumatic transaction of the aorta as well, which is a major vessel. So it is a severe injury, severe blood trauma, and if we put the chest tube on the both sides, and the patient will, we have to take the patient to the theater for the operation, for the not only for this but for the long bones fracture or the pelvic fractures, anything. So we have to put the patient to the respirator. But in this case, you have to, there are chances of developing the tension pneumothorax because of the rupture of the bulla. So this chest tube on the bilateral side, they will make sure that the patient will not have this problem. Okay. This is another scenario. In this, the severity of injury is not very severe, and there is just a contusion of the lungs because of the multiple injury sites. So initially, patient was fine for 1 or 2 days, but after that, then the lung become white. So these are the bruised lung parenchyma, and what we have to do, we have to do the fluid restrictions, we have to give diuretics because they are very sensitive to the fluid overload, and we have to give the respiratory support if needed. Chest tube only if mechanical ventilation. Okay. Now, in this scenario, the patient was clearly in shock. Blood pressure was 60, the systolic blood pressure. And the patient was in tension pneumothorax. And but where was the penetrating weapon? It was her fractured ribs, and they were sharp enough, and they causes in flail chest, they causes the penetrating injury to the lung parenchyma because of the their ragged edges of the fractured ribs. Now, in the treatment, as you will see in the next slide, we pass the needle, a large bore needle, in the second intercostal space in the mid-clavicular line. Okay. Even if you don't have anything, you can have a ball pen. You can take out the refill, and you can just put the hollow structure of the ball pen inside, and it will also help. Just think what you wanted to do is to make the air come out and the lung to expand and the patient to breathe. This is it. This is a life-saving measures. Okay. So usually we put the chest tube in the fifth intercostal space in the axial line, but this emergency measures put the needle in the second intercostal space mid clavicular line. This is the difference, in emergency and when you are at your leisure, when you've got the more time at your hand. Okay, chest X-ray will confirm the correct placement of the tube. If there is a discrete injury, in that you have to also think of the traumatic transection of the aorta, the large vessel. You have to think about it. Okay. Okay. Now, in this patient, there is a severe trauma. And why it is severe trauma? Because there is a fracture of the first rib. These are the few things which you have to remember. First rib fracture, sternal fracture, scapular fracture means there is a big trauma because these are the strong bones. They are supposed to protect the bony cage. But if they are fractured, that means the magnitude of the trauma was and the velocity was very much. Okay. So what is the underneath the sternum? Heart. So there are chances that there is a injury to the heart. There may be myocardial contusion. Okay, bruises over the heart itself. The treatment is just like myocardial infarction. You have to do the ECG, you have to do the troponin, okay, and you have to control the arrhythmias if they occur. Okay, and one more thing which I would like to tell you, that in this case, if you try to, if there is, for example, there is a collection of the blood over the heart and under the pericardium, which is known as the cardiac tamponade, there is a collection of the blood over the heart, so heart cannot expand. Okay, in this case, what happened, that there will be the patient will the heart sounds will be muffled or absent. Okay, but the thing is that in the patient there will be distended neck veins. So if there are distended neck veins, and there are muffled heart sounds, it is cardiac tamponade. And if distended neck veins and heart sounds are normal but muffled or less air entry into the lung, that means it is a tension pneumothorax. Okay, and it is also hyperresonant. So you have to differentiate between these two. Okay, so the important thing you have to keep in mind that distended neck veins, you have to have two conditions in your mind. Either it is a cardiac tamponade or it is a tension pneumothorax. If there is a problem with the lungs, that is the air entry is muffled, it is absent, and there is a hyperresonant, the tension pneumothorax, if it is a muffled or absent heart sounds, then that it means that it is a cardiac tamponade. Okay, this is a deceleration injury, so you have to again keep in your mind the traumatic transaction of the aorta, and you have to get the spiral CT. Okay. Now in this patient, as you see, there is a severe deceleration injury. Okay, and first rib is also broken. I told you that first rib and this medias, this sternum and this scapula, if they are fractured, that means this is a severe trauma. So in this patient, there is a widened mediastinum on chest X-ray, which tells you that there is a high probability of traumatic transaction of the aorta. And why? If there is a deceleration injury, the aortic arch, which is fixed, it keeps going forward, and descending aorta, which is fixed, also causes the aortic transaction at the junction. Okay, so aortic arch keeps going forward, and descending aorta, which is fixed, causes the aorta to be transect at the junction. If adventitious is spared, there will be a hematoma which eventually keep growing and eventually burst and death. So what you have to do is that you have to go for the spiral CT, which is diagnostic, because on chest X-ray sometimes there is only widened mediastinum and there is a high probability, but it is not diagnostic. So you go for a spiral CT, and if even if that does not prove it, then you go for CT angio, and then you've got only one choice, and that is the immediate surgical repair. If there is a severe deceleration injury and if it is hard to break the bones, the widened mediastinum on chest X-ray is one of the clues that there is a serious patient in your hand, and the time is tickling, and you are going to lose the patient if you are not going to take the steps at the appropriate time. In this slide, I told you that there are multiple fluid levels in the left side after the trauma. So this is a traumatic diaphragmatic rupture. Diaphragm is not there, which keeps the intestinal and the abdominal contents inside the abdomen. So they go into the left side, into the chest. Why not on the right side? Because on the right side we have got liver, you know that. So almost always we have got this kind of diaphragm on the left side. And the other way to check it is you have to put the NG tube, which will go inside and curl up, and it will appear into the X-ray on the left chest. Okay, so NG tube, if you pass and it will appear into the left side of the chest, this is also a diagnostic. If you are even then suspicious, you can also use the laparoscope for evaluation, and the treatment is surgical repair. Alright, okay. Now, as we have discussed before, that there is a condition in which there is a collection of air under the skin, which is known as subcutaneous surgical emphysema. Okay, so there are three things which give thoracic subcutaneous emphysema. Number one, esophageal rupture. Usually, it is done by iatrogenic. That is, iatrogenic means by the doctor. Okay, and usually it is done while doing the endoscopy. Okay. Second, tension pneumothorax. It also causes this. Patient is usually in shock with distended neck veins, as I told you, and respiratory distress. And third one is traumatic rupture of trachea or major bronchus. So these three conditions cause the surgical emphysema, and we have to do the chest X-ray to confirm the presence of air in the tissues, and fiber optic bronchoscopy, which will confirm the diagnosis and the level of the injury as well. We have to secure the airway. If you do blindly intubate, you will not inflate the lungs, and then you have to surgically repair the tear where it is. Now, this is also very important condition. In this, there is a severe trauma and no chest injury, but present with respiratory distress. Why? Because of the long bone fractures, and from the long bones, there is a fat droplet which goes into the circulation, causes the fat embolism. So please remember this fat embolism. This is a scenario which is very important. At every level, they will ask you the question about this, because the patient was fine after the fractures or whatever, but because of this fat which comes into circulation, it causes a blockage to the normal flow of the blood, and patient become hypoxic and patient died. The fracture of long bones of the legs especially, they are very important in this case, that they causes this fat embolism. And how can you diagnose? You can diagnose it with the petechial rash, which will develop in the axilla and the body, and there will be fat droplets in the urine. Okay, and so these patients, what you have to do, you have to suspect this condition, then you have to look for the signs, and you do the X-rays, which also show the patchy infiltrates, and then you give them the respiratory support, and the patient will be fine. So I think, children, I think this is more than enough for your level, but I try to concise things. But this is so important that I have to tell you all these nomenclatures, the words, and the different meanings of the words, that what is pneumothorax, what is tension pneumothorax, what is cardiac tamponade, and what is fat embolism, because every doctor should know about it, because this is a life-saving. And by knowing this lecture, inshallah, you'll be able to save many lives, and you'll be happy, inshallah, to see you in next lecture soon. Take care of yourself, okay?